Hello, students, and welcome to Chapter 29. This is the complete physical assessment for infant, young child, and the adolescent. We're going to be able to use the recommended techniques to perform a complete history and physical of the infant, the child, and the adolescent. So for the infant, we want to be sure that we get vital signs and measurements for the infant. For the most part, that baby is going to be supine. They're going to be laying flat. Um, or it all depends. I mean, you could be in a doctor's office and they're sitting in their parents' lap. That could be as well. So we want to start with vital signs. The reason we do vital signs generally when they are quiet, we haven't yet disturbed them, and so everything will be normal, quote unquote, at this point. Because once they start crying, then we know that, of course, the respiration is going to be off, their heart rate's going to be off. So you want to be sure you get these things while the baby is quiet. So you're going to check their pulse, check their respiration, and then their temperature. So notice we start with the pulse and respirations first. That you can do really quietly without really affecting the child. And then we're going to look at the weight. The weight we can actually do with maybe on a bassinet scale for the baby. You're also going to check the baby's length by measuring the baby's length. And then we're also going to measure the circumference of their head as well. Now, a newborn's head is about 2 centimeters larger than their chest. And after about age 2 or so, then when they start growing, the chest becomes a little bit larger than the head. So we don't have to do that. But normally, the circumference of the head is measured every visit until that baby is about 2 years old. And then they do so yearly until that child is about 6 years old or so. We also want to compare it to a growth chart, by the way, to make sure that these babies are meeting their developmental growth. So we start with general appearance. And so you're going to look at the symmetry of the baby's body. You're going to be sure that everything is symmetrical, that their positioning normally is symmetrical, and that we have spontaneous movement from the infant. Unless something is drastically wrong, generally you don't often find any problems here. You look at skin color. Is it appropriate for that infant's ethnicity? And do they have additional problems? Is the skin color yellowish? Jaundice, maybe? You could note that. All depends. And then is the baby alert? Um, if they're crying, what does the cry sound like? Is it a nice, healthy cry, or is it a very poor cry for that infant? We want to be sure we inspect the skin over the baby's chest and their heart area. Make sure that the skin is intact like anything else. You want to check the temperature of the skin. We want to look at what the chest cavity looks like to be sure it's symmetrical across. Look at the baby's breast tissue. Sometimes you may see the breast being a little bit engorged. Of course, this is going to be for a new baby, influence of mom's hormones. And then you're going to palpate the apical impulse for the baby. Now their thoracic cavity is much shorter. So of course you're going to find um, these would feel a lot, well, you'll feel it in sort of over a larger area of the chest cavity and just than the one spot, simply because the thoracic cavity is so small. So you're going to palpate for thrills as well and tactile fremitus. This, of course, you can feel, especially if the baby is crying. And then you're going to listen to the heart sounds in all the location. And then be sure that for the infant, you're going to move down to the abdomen, and you're going to also do the same with the abdomen as well. Now, sometimes babies are born with cardiac issues like tetralogy of Fallot, etc. So you want to be sure that you're listening appropriately to these sounds. Now for the abdomen, of course, you're going to begin with inspection. So look at that shape of the abdomen. Look at the skin over the entire abdomen. Now on their abdomen, you may actually, for a new baby, of course, you'll see their umbilicus or umbilicus, the cord that's still there. When you look at the cord, you should see two veins, two arteries and the veins over in the cord itself. Mostly it's going to be clamped, of course, and then depending on the age of the infant, in varying stage of healing, or sometimes that would have fallen off. It all depends. When you look at the infant's abdominal area, you can sometimes see what's called diastasis recti, especially over African American infants. And this is where it looks like the muscles of the chest in the abdominal area actually haven't come together yet, that they're apart. Usually by the time the child is 6 years old, they would have outgrown it, so you wouldn't see it anymore. But you want to look at the abdomen. Now but you may see when the baby breathes that they're using their entire, because their frame is so small, so it looks like they're doing abdominal breathing instead of chest breathing. And that is simply because their areas are so small. You want to assess skin turgor of the baby as well. You want to palpate the abdomen, and you're going to palpate the areas same as you would for the adult, but you're feeling the little areas maybe around their liver and their spleen. You could probably feel their bladder, and their bladder will of course come higher up than what we normally would. It wouldn't be in the suprapubic area, but you can actually feel it up to their umbilicus because their frame is so small. And of course then you would be auscultating their bowel sounds as usual. So you begin with inspection, then go with auscultation. That is still appropriate. And of course, you can always percuss as well. For the head and the face, for the babies, you're actually inspecting for any swelling in the baby's head, bulging. You're looking at the fontanelles here. And you can sometimes see the bulging, especially if the infant is crying. You may see it bulged out a little bit more. Of course, when you palpate it, these are areas that are really soft, and you can actually feel the spaces in between the bones. You're looking for symmetry of the baby's face, especially when they're crying. You could see that the face is symmetrical. You're going to look in the eyes as well, and you may have to open up some eyes, especially for the newborn baby, to see if you can see in their eyes. You're again looking at the conjunctiva of the baby's eye, and if this is a newborn baby, you want to be sure that they don't have like pathological jaundice. A few days old, and you may begin to notice jaundice on the infant as well. So the lids of the eyes could be a little bit edematous for the newborn. You're still looking for the kind of nystagmus. Of course, you have to get real close for the baby to the baby's face in order to follow some things, for the baby to follow things in their field of vision. You're looking for any kind of discharge from the eye. So babies should have reflexes in their eye as well. So they should have a blink reflex, a corneal reflex. You're going to assess that with the light. So pupillary light reflex should be there as well. With the ears, we're going to look at the same for the ears as the adult. So you inspect, you palpate. Now, of course, with the babies, they can't tell you whether they can hear things or not, right? So you would not be doing like a whisper test with the newborn. Of course, you can check their hearing by sort of making a very loud sound and see if the baby's startled. If they startle, then you know they can actually hear the sound. But we won't go and look in the baby's ear. Probably you want to, if this is done, you want to make sure that this is the last thing that's done. You want to check out patency of their nose as well. The newborn generally want to suction out, stuff from the birth canal out of their nose. And the older baby, you want to always be sure that their nose is patent. for, well, this is the baby, so the babies wouldn't be putting things in their nose, but of course you want to be sure that their nares are patent. And then you're looking for any kind of discharge. You may be seeing a lot of sneezing from the infant as well. You're looking for respiratory flaring, especially for the newborn baby, because remember, this is the first time that the respiratory system is now working fully. So you want to be sure that the baby is not turning blue or cyanotic, using the accessory muscles to breathe. So you want to pay attention to those things. The mouth, the throat, and the neck, you want to be sure to inspect the patient's mouth. Now, when you look at a newborn baby, there are some babies that are born with real teeth, and then teeth or sort of teeth, we call them Epstein pearls, that are not quite teeth. You want to be sure that you look at the tongue, the frenulum, to be sure it's not very short, because there are some children born with very short frenulum, and so they can't really extend the tongue. And we need the tongue to be appropriate because it will help them with nutrition, right? Sucking reflex, etc. And the baby really won't have a whole lot of salivation, so you won't see a whole lot of moisture in their mouth at this point. They should have the rooting reflex, and that is if you put your finger up against the side of your cheek, they should start looking for food by pulling sideways. And then sucking reflex, if you put your finger in their mouth, they should start sucking on that finger. Or if you put your finger up towards the palate, you should start to feel that sucking on the finger itself. So those reflexes should be intact. For the extremity, you want to look to be sure that the patient can the baby can move all their extremities. So you're looking at range of motion. They won't have a whole lot of muscle tone, but they should have some muscle tone. The muscles shouldn't really be flaccid. Like if you hold the baby's upper extremity, there should be some tone to it. It shouldn't be like picking up like a scarf, etc. And speaking of scarf, you're also looking for the scarf sign. And what that is, you know how a scarf, how you throw a scarf over the neck? Well, sometimes when the babies are born vaginally, they sometimes end up with shoulder dystocia or dislocation of the shoulder. And so you'd find that one arm, if you put the arm across the chest to the other arm, to the other shoulder, then sometimes one arm, if it's dislocated, will be more than just the shoulder. The hand will reach more than just the shoulder. You can actually throw the arm over the baby's shoulder all the way over it like a scarf. So that's why they call it the scarf sign. And this would give you a good sense that the baby's shoulder is actually dislocated. Then you want to look at how many fingers. We want to be sure we have appropriate fingers. Sometimes babies are born with extra digits, right? And look at the coloring to make sure there's no cyanosis or jaundice going on there. They should have the grasp reflex as well. If you put your hand in their palm, they should grasp you. And then head lag, generally, again, the baby should have some tone. So if you pull the baby up by the hands, their head, because they can't really manage their head too much, should actually lag behind. It should fall. That's why we have to support a baby's head, because they don't have good control. The head is heavy. Lower extremity, you want to be sure that you assess for range of motion. Again, some muscle tone in the infant. You're going to look at skin integrity as well. The feet should have appropriate toes on the feet as well. You're checking for extra digits here as well. The baby's hip could also be dislocated through vaginal birth. So we want to check to see if the baby has positive ortholani sign or instability of that hip. And what we are doing is we're checking for any kind of clicking sound that would be appropriate as you are doing an external rotation of the baby's hip. And your book gives a good picture of what that looks like. And then on the plantar surface of that infant, they should actually, if you put your finger right in their soles of their feet, they should actually try to like hold on to your finger. So that's a plantar grasp reflex. And The Babinski reflex, again, is where we draw an upside down J, and the baby should really fan. And that would occur until the baby's about maybe 2 years old. Then it will go away. The genitalia of the baby, for female, you will see it a little bit engorged or swollen, the labia of the clitoris, and this is because of the mom's hormone levels influence, and that'll go away. You may also on the skin see vernix caseosa, that is that just white cheesy look on the baby as well. That would also be in the vaginal crease area. And we don't try to, clean the vernix off the baby. Again, it's protective of that infant. We don't give them a bath right away. We actually leave it intact, so just clean the face off the newborn baby, just so we can protect their skin. For males, we don't try to retract the foreskin because the area is so small. We may actually try to rip it, so we don't do that for the males. When they're urinating, and of course, especially if it's a male and they start urinating, just be aware that they're not trying to shoot you with their urine. But on the male, you want to look at their scrotal sac. It should have rugae on it, which is that sort of corrugated look. And also their testes should have been descended. So you want to feel for that as well. Sometimes for newborns, you don't have, or you will have undescended testes. So you want to be sure that the inguinal area are sort of closed off, because sometimes when you try to assess it, the testes actually want to slide back up that canal. So you want to close off these areas before that's assessed. So neuromuscular wise, you want to be sure that you assess the baby tone. And what that is the baby should have some muscle tone, okay? You're going to hold the baby under their shoulder, and really they should do a few things when you actually do this hold on the baby. They should actually have a stepping reflex when you start doing that. And they should be able to try to hold themselves up while you are holding them under their shoulder. That gives you a sense that they do have some muscle tone. Now, you can move the baby's head from side to side, and the baby's eyes sort of will not be in a steadfast position. You see that their eyes will roll with the head. So this is called the doll's eye reflex. After a while, when they start learning how to focus, then that baby will hold the focus of the whatever is in their view. So you want to look at the spine and the rectum as well. Each gluteal fold should be symmetrical. You want to be sure that it is the same left side and right side. Also on the back, you want to look for any opening along the spinal column. Okay, so we want to be sure that there is no opening there, because some babies that are born with deformities can actually have their spinal cord protruding through their skin or back opening. Sometimes you may see even some tufts of hair normally on the infant's back as well. So you're looking for sort of spina bifida or any kind of deformities in the infant. And the baby's buttocks, we don't want to do a rectal exam, but remember what I said about the GI system being patent and open. The only way that we're going to know this is if the baby has a stool. So that first stool, called the meconium stool, usually occurs within 24 to 48 hours. But there should be an open area generally for where the anus is. That should be open. So the physician or the provider would also utilize an otoscope and look in the baby's ear as well. And here I said before that the baby you won't be able to do a whisper test with that child, but if you give a large sound, like a clapping of the hand really loudly, that baby should startle. That way you know that that child can actually hear you. So we elicit the moral, it's called the Moro reflex. Now for the young child, this child is growing a little bit more um, independent, and so they'll be able to help you a little bit with your assessment, right? But of course, they're going to be afraid of some things. They're afraid of things hurting or harming their body. So you may have to do a demonstration on mom sometime before you actually use whatever equipment it is you're going to be using on them. That way it gives them some comfort that it didn't hurt mom, so it won't hurt them as well. Okay, so they're developing school-age children, cooperative, and they're trying to be interested in knowing what's going on with their body. So initiative is what is the developmental task for the child, school-age child at this point. So the history information is going to come from mom. And remember, be patient with mom because she may have had multiple children, and so she have to pick through what information is pertinent for which child. So you're going to look general appearance on the child. That child should be able to be playing by themselves and, you know, keeping themselves quiet, amusing themselves. And then one of the things that you want to do is you want to look at the interaction between the parent and the child. Again, you're going to check for abuse. Not that you're not checking for abuse earlier, and you would, but you're also looking for abuse. Remember, we're mandated reporters in all areas, right? So you're going to pay attention to mom first and then move your attention to the child and then start evaluating the child from there. But they need to get comfortable with you before they allow you to do anything with them. So we want to be sure when we're assessing them that we're assessing for them reaching developmental milestones. So for a younger child, they should be able to be, you know, sitting up. They should be maybe attempting to start walking on their own, and they should be able to start to develop speech. So you're going to be looking at, you know, the words that they're saying, how they're saying these words, and their vision should be also appropriate at this time as well. Now, if you assume, believe that the infant is not able to see, then there are other assessment that can be done, you know, because we see younger children in glasses simply because it helps them to see, and that's a sensory function that we want to be sure is developing appropriately. So upper extremity, head, face, and neck, you're going to inspect, palpate, auscultate these areas. So you want to look and you know, see what the skin color looks like. On their face is symmetrical, neck is symmetrical. They should have creasing appropriately. You want to palpate the patient's pulse. Regarding reflexes, this is time where you can actually begin to do reflexes on the child. The shape of the head you want to look for symmetry here. Lymph nodes you can assess, and remember the lymph nodes in the child more likely will be, you'll feel more edematous lymph nodes because there's function. They have a lot more lymphatic fluid and it functions more than generally the adult, so you'll be able to actually feel more lymphatic tissue. So thyroid gland you can also palpate as well. So the eyes, you're looking at the structure of the eyes. You're looking for any kind of discharge coming from the eyes. You're going to be able to do the same with pupillary light reflex from the eyes. You can do cover tests with the infant to be sure that their eyes are focusing appropriately. You're going to look to see if there's any discharge coming from the eye, looking for conjunctivitis. You want to look at the sclera of the eye. Okay. And if you look in, you want to see the red reflex if you use an ophthalmoscope in the eye. The nose, the mouth, the throat, you begin with inspection as well. Now, remember these children play with toys. Sometimes the toys have small pieces. So you're going to be sure that nothing is blocking any kind of orifice. You want to be sure that these areas are patent. So you're inspecting, you're looking at, and not only toys, but also food particles as well, like peas or corn, anything that sometimes these children try to place in orifices that are not appropriate. So be sure that these areas are patent or open. So look at the external nose, look at the mucosa, the septum of the nose, looking for turbinates as well. For the mouth and throat, look in their mouth, look at their teeth, look at the patient's uvula sometimes, look at inside, have them say ah to make sure that that moves as well. And be sure that you put things in the child's mouth that probably one of the last things that you may want to be doing. Look in their ears. You want to inspect and palpate the ear of the patient. Look for discharge, look for any kind of foreign body in the ears itself. Look at the tympanic membrane, and you're looking for the same thing as you would for the adult itself. And this is especially one of those equipment that they probably don't want you to put anything in their ear. So you may have to demonstrate on mom first, have them hold the otoscope before you even utilize it. And the chest, thorax, and breath sound, you're looking at the chest cavity. You're inspecting for symmetry. You're looking to see if they're using accessory muscles to breathe. And then, of course, you're going to palpate for any kind of tenderness, any lumps, etc. And then you're going to be auscultate, percuss. You're going to percuss over the lung fields. You're going to look for resonant sounds. You should be hearing that. And then you're going to listen, auscultate breath sounds, and you should hear clear breath sounds unless the patient has adventitious lung sounds. You could hear that as well because we do have children that has asthma. So you're listening for those adventitious lung sounds. Look, inspect for any kind of heaves or lift from their heart, any kind of pulsations in the area. Palpate the apical pulse, so PMI, and that may be found like fourth intercostal space or so. You're going to palpate for tactile fremitus, so they can help you by saying 99. It'll be fun to them to do that. So listen to what the heart sounds like. Listen for extra sounds in the heart as well. So you should be hearing S1, S2, but you're going to also listen for murmurs. When you get to the abdomen, same thing occurs. You're going to inspect the abdomen. Look at the skin color. You're going to inspect the shape. So what does it look like? Mostly you'll see protuberant abdomen, and their umbilicus. You're looking at this area because sometimes we can see hernias, like umbilical hernia, that occur as well. And then you are going to listen for bowel sounds. Okay, so either active, hyperactive, hypoactive bowel sounds. And then you're going to palpate, same thing in the abdomen. You're going to look for the liver edge. You're going to look for the spleen, the kidneys as well, and any other masses that could be found in the abdomen. And then you're going to, you can percuss. You can also even auscultate for vascular sounds as well. And then you're going to inspect the genitalia of the child. You want to be sure that everything is still developmentally appropriate, and you want to compare them to the developmental chart. Okay, and of course, as they're getting closer to having sexual development, then you're going to be utilizing Tanner's sexual developmental rating chart. So you also want to be sure that you palpate the scrotum for testes in the males as well. So extremities, you want to look for Ortolani sign, and that's just hip dislocation. You want to be sure that both extremities are the same length, so you may want to measure for those. So you're going to also do range of motion on the lower extremities, so the hips, the knees, the ankles, like you would be on the adult. And then you're going to check strength as well. You can also utilize the reflex hammer by checking the reflexes, lower extremities. You'd also be checking the reflexes, upper extremities as well, if I had not stated that. Now, moving to the adolescent, how do you think you'd be able to do the assessment? Head to toe assessment or focus assessment? You'd still do a head to toe assessment on the adolescent, just like you would a adult. But of course, the adolescent, the major developmental task here is identity. So they want to try to identify who they are. They're not quite an adult, but of course, they're not quite children either. So they're in between and they're trying to become a little bit more independent. So they're a little bit more self-conscious, trying to be a little bit more introspective, and they're trying to be like friends. So they're going to try to take on the identity of friends. So their dress, how they talk, may imitate friends that they have. But when we do the assessment, we're still going to do a head-to-toe assessment on the adolescent. If you're in a healthcare facility, they can actually keep their clothing on for the moment, and then you can assess the body part area by area without actually having them remove the their entire clothing. So you want to begin just as you would the adult, do a head to toe format. So start with the head, the face, the neck, and you move your way down. And then when they are in a supine position, then of course you're going to be doing the cardiac assessment. You're going to assess their abdomen, etc. And then for the low extremity, they can always lift up the legs of the pants for you to assess. So here's a case study that you may want to consider. JP is a 12-year-old boy. He presents to the pediatric office for his annual visit. So subjective data, he lives with mom and dad, both present for the visit. He attends upper elementary school. He's the only child. No smokers at home, no weapons in the home. Objective data, you've got vital signs within normal limits, height and weight within normal limits, immunizations are up to date, no medication, no allergies, and physical exams within normal limits. So some questions for you to consider. What special consideration should nurse keep in mind regarding the physical exam with that age group? So think about it. He's 12, so what are you going to consider? Now, what similarities does the assessment of this age group have compared to the adult exam? So how is the assessment for this 12-year-old the same as the adult exam? What are the expected findings for the skin, the hair, the nails, the musculoskeletal system for this 12-year-old? What are some abnormal findings for the skin, hair, and nails and musculoskeletal system that you could possibly find? And then how should the nurse assess the reproductive system for boys in this age group? And which stage of development is this patient using the Tanner's stages for boys? Hopefully you'll be able to answer those questions and find the answers to those questions.